All right. Good morning, pediatricians and Pittsburgh. Yeah, so I'm very excited because it's going to be like 73 today, sunny. And also we have this amazing grand rounds this morning by two of our leading clinician educators in our department. So I have the privilege of introducing them. So on behalf of my colleagues who also serve in the Office of Faculty Development for Pitt Pediatrics, I have the privilege of introducing our speakers this morning who are presenting a topic in the domain of medical education, which is very timely given the current reforms in the curriculum at Pitt Med. Dr. John Szymusiak is an assistant professor in the Department of Medicine and Pediatrics at the University of Pittsburgh School of Medicine. He received his Bachelor's of Science degree from the University of Michigan and completed his medical school training at the University of Cincinnati College of Medicine. He completed residency in internal medicine and pediatrics at the University of Pittsburgh Medical Center, serving as a mid-piece chief during his final year of training in 2015. After completing his master's degree in medical education, he joined the University of Pittsburgh as faculty, becoming a leading clinician educator with roles including associate chair for undergraduate medical education in the Department of Pediatrics, Clerkship director for the third year pediatrics clerkship, and associate program director of the internal medicine pediatrics residency program. Dr. Szymusiak has received multiple teaching awards, presented his scholarly work at national meetings, published widely in peer-reviewed journals, and recently received the University of Pittsburgh School of Medicine Outstanding Early Career Educator Award. Dr. Andrew McCormick is an associate professor in the Department of Pediatrics and Medicine at the University of Pittsburgh School of Medicine. Dr. McCormick received his Bachelor's of Science degree from Grove City College, then completed his medical school training here at the University of Pittsburgh in 2007, and his residency also here in internal medicine and pediatrics in 2011. Following residency, Dr. McCormick joined the Paul C. Gaffney Pediatric Hospitalist Medicine Division, and he served as the medical director of the Vascular Anomaly Center. Dr. McCormick is a multifaceted clinician educator, leading clinical research projects related to the care of vascular anomalies in patients, implementing innovative curricula across the continuum of medical education here at Pitt Med, serving as course director for undergraduate courses at Pitt Med, and spearheading numerous quality improvement initiatives. He has received numerous research, service, and teaching awards and grants. In addition to being inducted into the University of Pittsburgh School of Medicine Academy of Master Educators, Dr. McCormick has developed a national profile in his multiple areas of expertise. We are truly thrilled to have Dr. Szymusiak and Dr. McCormick share their wisdom and expertise with us this morning with their presentation, Training Tomorrow's Doctors Today, the Curriculum Reform Process at the University of Pittsburgh School of Medicine. Please join me in warmly welcoming Dr. Szymusiak and Dr. McCormick.
Thank you, Mel, for the very warm introduction, and thank you to everyone who is joining us both here in person as well as virtually. I'm very excited to have the opportunity to share with you a little bit about a lot of the exciting work that has been going on at the University of Pittsburgh towards curriculum reform. I will also ask that you all excuse my hoarseness. My daughter started daycare about 6 weeks ago, and I think this is back-to-back viral illness number 4 that she has passed on to me. So her voice is going to get much better than mine is. But all right. So just to give you guys a kind of roadmap of what to expect from today's lecture. We're going to begin with kind of giving an overview of the rationale for undergoing curriculum reform. We're going to review some principles of adult learning that kind of drove a lot of these changes. And then we're going to give a big picture overview of the changes that are occurring both in the preclinical years and the clinical years, and then finish with some practical next steps that all of you as pediatricians and pediatric faculty can do to become more involved in the curriculum reform process. We also do have a couple of learning objectives. A lot of the content is going to be more sharing the work that's been done. But our hope is that at the end of this presentation, all of you will be able to describe the basic principles of adult learning, as well as to describe some evidence-based techniques that have been proven to maximize learning in adults. So to begin with, we wanted to give an overview of the work that has gone on so far in this reform to create this new Three Rivers curriculum. So phase one of the curriculum reform began all the way back in 2019. And this phase consisted of basically a needs assessment where we kind of reviewed what's being done at Pitt and confirmed that we did all agree that there was a need for curriculum reform, as well as a review of what other schools who have recently undergone curriculum reform have done. Phase two then started right afterwards in 2020 and was completed in 2022. And in phase two, we were really focused on getting a big picture outline of what this new curriculum will look like. So how long is the preclinical portion going to be? What are the core clerkships going to look like? How long will students have after completing those to complete their kind of beyond portion of their clerkships? And then finally, phase three started immediately after phase two and was just completed in March of 2023. The final report was created and actually was just approved by the curriculum committee this past Monday. So also just to give you all an overview of kind of what Dr. McCormick and my role in curriculum reform has been, just so you kind of have an idea what are probably the topics and questions we can most intelligently comment on if you have questions. I've been a part of various phases of all three of these parts of curriculum reform. In phase two, I led the clinical curriculum working group and was also a member of the steering committee. And then in phase three, focused on kind of how to handle the type of students that's going to be occurring as we transition between the current curricula to the new Three Rivers curriculum. Dr. McCormick took on the enormous responsibility of serving on the steering committee for phase three and was also involved in a working group focusing on the community partnerships that will be a part of the curriculum. And we were not alone in phase three. There were about 30 faculty from the Department of Pediatrics who participated in various roles, several of whom I see here in the room right now. So thank you all for your commitment and hard work towards making sure that we as pediatricians have a voice in shaping this curriculum. And then just to give an idea of when all this will be starting, the answer is very soon. So the medical school is enrolling and has enrolled many students to this first class of the Three Rivers curriculum, and those students will be matriculating this fall. So kind of August and September will be coming and starting the curriculum. So in just a few months, we will be getting to see the fruition of all this hard work. So some of you may be wondering yourselves, like, why did we do this 4 or 5 years of work of hundreds of faculty members? Like, it's a really good medical school. Like, it's not what are we trying to fix? So phase one did identify some areas that would benefit from some updating in the Pitt Med curriculum. There's agreement between both faculty and students that students should enter the clinical curriculum earlier on, that we should be trying to shift away from lectures towards more active case-based learning, shifting towards a smaller pool of educators who will get to know the students more longitudinally, focusing more on social determinants of health in our curriculum, changing our testing philosophy to more of a frequent low stakes testing model, and finally providing students more options for individualized learning. Beyond the results of this needs assessment, everyone felt very strongly that we're not okay with it by just being good. We want to be great. We want to be the best. We want to be at the cutting edge of medical education. We want to be training our students to be providing excellent care. And we want to be teaching the students how to do this in ways that are aligned with adult learning principles that provide an evidence base for how best adults learn and how best to train these medical students. So we're going to transition now to talking a little bit about some of the basic principles of adult learning that help to inform a lot of these changes that were made, as well as highlighting a few evidence-based techniques to maximize learning in adults that this new curriculum is trying to leverage. And I'll try to point out the various portions of the new curriculum that are accomplishing these various techniques. So the first thing I think that's really important to keep in mind is that adult learners are goal-oriented and they're pragmatic and practical and motivated by relevancy. And that was a lot of what drove this shift from kind of the more traditional kind of first year of very basic science focus, second year of kind of organ systems, and then moving into the clinical curriculum. They wanted to get students kind of right away learning why this information they're learning is relevant to the care they're going to be providing to these patients, and what their end goal is to be really excellent doctors. So the hope is that by moving to a more case-based curriculum, we can still give them this very important foundational content, but give them also a little bit of context about why it's important they learn it. There's also been a shift towards giving students much earlier clinical exposures with both standardized patients and real patients. All learners are also autonomous and self-directed. So to this end, there was a push towards moving away from more passive learning in lectures, which, don't get me wrong, a lot of lectures can be really interactive and participatory, but moving towards more active learning in small groups. Also an increase in kind of independent study time, where students can do asynchronous learning and kind of try to identify for themselves what their learning needs are. And finally, adult learners utilize their previous experiences and knowledge. We are really fortunate to have such an amazing and diverse group of medical students here at Pitt with such diverse life experiences and perspectives. And we wanted to make sure that we were letting the students learn from their peers' unique perspectives and experiences. And again, we thought that having small group learning would be a great way to do this. So those are some of the principles of adult learning and how we're trying to apply them to the curriculum. We're going to shift now to some evidence-based techniques for maximizing learning in adult learners. So the first technique I wanted to highlight is interleaving. And interleaving is defined as mixing two or more subjects or skills into a single learning session. So for example, if you were teaching someone to play soccer, you don't want to just have one practice only be dribbling, one practice only be shooting, one practice only be passing, because that's not what the athlete is doing in their day-to-day, right? It's much more effective to teach them how to combine all those skills. And there's research in educational literature that this interweaving leads to better mastery and long-term retention in adult learners, as does the more kind of siloed educational approach. So this is a big goal of the move towards a more case-based curriculum. And Dr. McCormick will give you some more concrete examples of what this will look like. But the idea is that for each case, you're going to be mixing in relevant topics from physiology, biochem, pharmacology, pathology, anatomy, and so on into a given week's case. Similarly, we're trying to move from less of a siloed individual organ systems-based curriculum where you just do the lungs for 2 weeks, you just do the heart for 2 weeks, to a more integrated approach where you can kind of really give the students an appreciation of how all of these systems function together to maintain homeostasis and kind of normal function. The next topic I want to talk about is spaced learning, which is when you're kind of revisiting the same material over a period of time. And I have to compare this to, imagine you're walking through the forest, and this is a completely, no human being has been in this forest before. The first time you're kind of trying to walk that path, it's really hard, right? There's tree branches you have to hack through, and there's underbrush that you have to kind of trample over. It's hard the first time. And let's say you continue to walk this every single day. Each day it gets a little bit easier. You kind of build yourself a trail until after doing this many times, you have this pretty easily navigable path like you see on your on the slide here. The same idea goes to learning new material. The first time you're trying to learn it, it's hard. Like your neurons are rewatering, you're figuring this out. And as you kind of continue to revisit that material, you become more comfortable with it. You're able to retrieve it more quickly and more effortlessly, which then frees up cognitive load to focus on other new skills. And consolidation is kind of the term that is used for this in a lot of the psychological and educational literature. So our hope is that by having students kind of revisiting the same case over multiple days, over a week, that they will have this ability to kind of do the spaced learning and get a better understanding of the big picture with less siloing of their knowledge. Test taking is another portion of the curriculum that's kind of changing the approach. So traditionally, students have the kind of high stakes, kind of end of course, summative evaluations that I think many of you, at least I was kind of familiar with in medical school. And there's a lot of really good literature that students actually do better with frequent low stakes formative assessments. And this kind of makes sense, right? Like these assessments provide a signpost to learners how they're doing. The same way when you're working with the medical student on the wards, they really hate when you wait till Friday to say, hey, like, you've been doing that presentation wrong all week. Like, they would much rather do that on Monday so they have time to course correct and learn. Similarly, these low stakes formative assessments give students an early opportunity to identify where they should be focusing their studying efforts. And again, this is also a way to kind of encourage this spaced repetitive practice where they're being reintroduced to a topic over and over an extended time, a period of time. So I'm going to now hand off to Dr. McCormick to talk a little bit about the preclinical curriculum.
Thank you, John. And I really appreciate what we just talked about in this section, thinking about what is the rationale of why we decided to have curriculum reform. I'm going to move into a section specifically tailored toward thinking about the preclinical years. When we do this, I want you guys to have two things in mind. What I'm going to do is to hopefully take you from the most big picture view and then narrow all the way down to what the experience is like for our students as they are working and walking through this curriculum. The other thing that we're going to highlight is where, as a Department of Pediatrics, can we integrate with the curriculum? We've already started doing this as people have been applying for some of these dedicated educator positions that I'll talk about in a little bit. But I think that there's also some nice hot spots within the curriculum that we as a department can utilize to give early exposure to our students for pediatrics. And I think this is really key, right? We know that the pediatric workforce is an area where we need to work on recruitment. And the earlier we can get our students here at Children's are experiencing and mentoring with our faculty, I think the better opportunity we will have. So we're going to take what John just talked about with the rationale behind why we're doing new curriculum, and we're going to operationalize it, right? We're going to focus on this idea of adult learning pedagogy. How do we create an active learning environment? And specifically, we're going to be talking about a tighter and more integrated curriculum. We're going to talk about a flexible curriculum, right? Autonomy is really important for students. So how do they make their medical education unique for themselves? And then we're going to also talk about the idea of assessment. Assessment is going to be a really important part. In fact, it's going to occur every single week in the curriculum, but in a way in which often we do as we're studying for our boards, right? The idea is taking tests and get immediate feedback so that you can think about where are your gaps and then fill those gaps. So, like I said, we're going to take the most big picture view we can start with. And this is the 10,000 foot view, right? This is looking at the full preclinical curriculum in a snapshot. And there's two really important things that I want to highlight here, right? Thinking about adult learning theory, we want it to be goal-directed, we want it to be autonomous, we need to have flexibility within it. So the first thing you're going to know is it's going to be an extremely compressed schedule in comparison to what has traditionally been taught. The curriculum is going to occur over 15 months. So instead of our students kind of being wrapping up their basic science organ system block in March-ish, and then moving towards thinking about board studying and then moving into the clinical sphere around May, we're doing that at the end of November. They're going to be moving into December, already starting to do board studying. So it would be the beginning of the new year, they're going to be changing their mindset, getting into those clinical spheres. This is important for autonomy and flexibility for our students because we know that once you move into the traditional the first clinical year, you're often going through a regimented course work. We're giving students the opportunity to do early experiences in areas that may not be exposures they have. They can do electives earlier, get things under their belt that they can try something else. So if you're interested in neurosurgery, you can do that much earlier in your curriculum. If you're interested in specific areas, testing the water, so you're not waiting till late in third year or fourth year to really get that experience. So first, it's going to be a compressed. The second thing that's really important when we think about a compressed schedule, the most pushback we hear is that, whoa, are our students going to be able to learn all the basic science, all the organ systems that they're able to do to be ready for the clinical years? And the answer to this is yes. There's going to be some important concepts of mapping, making sure we know the learning objectives early, and then the integration piece where we're not learning one single course at a time, but rather integrating through this time that we can actually consolidate this in an effective way. And we're also teaching our students, hey, that the first 2 years of medical school is not about learning all the knowledge you need. It's the starting place. It's the launching pad so that as you're moving through, we're teaching our students to be clinicians at the beginning and realizing they're going to be educated, learning for their whole life. So the compressed schedule is really the starting place of their whole education. The second thing we're going to talk about is this really important concept of flex weeks. This is something that is new in the curriculum and really important. And I think you can see here, I'm clicking through and you can see that there's going to be 6 different flex weeks in this 15-month compressed schedule. This is the opportunity for students to pause from the scheduled curriculum and think about ways in which they can augment this curriculum for themselves. Now, there's going to be kind of 5 different kind of pathways of what they can do during these flex weeks. And this is also highlight an opportunity for us as a Department of Pediatrics to get early exposure for our medical students. The first 2 are going to be really key areas. The first one is a PEC. So a PEC, you guys may not know what PEC is, but it is what was traditionally known as a mini course. It's also now called a personal enrichment course. And the idea are these are brief courses, usually about 4 sessions lasting 2 to 4 hours each session, where a student can learn something that is adjacent to their medical experience. An example, POCUS. We know that our Department of Pediatrics has already offered some POCUS courses, the point of care ultrasound, teaching our students that early exposure to a skill. We also have courses on education, having around conversations, having difficult conversations with patients. How do we navigate that? A higher level skill than what they're learning in their introductory courses. We also have an art of medicine course. How do we integrate the history and art of medicine into our education? I also think about one of my colleagues, Tony Tarchichi. I'm going to put a quarter in the PHM collection pot, because anytime we talk about Tony in the podcast, we all have to put a quarter in there. But I'll just give Tony that that idea. He said, "I love podcasting. This is something that is unique. I'm going to create a PEC," and he created a PEC to offer our students the understanding of how do you do medical education through podcasting. That is a great way for our students to meet Tony, see what pediatrics is like, and develop mentorship. So we can all think about what are some ideas that we can start developing some courses that may be unique skills that we have, getting us out there to develop our curriculum skills, but also bringing our students into pediatrics to understand what is it like to be part of our community. The second one, also a hot spot, is shadowing. Shadowing has been going on for a really long time, but this is going to be a unique way in which students can shadow in a more structured, organized fashion early. Now, I will tell you, the important thing about this is shadowing has not been talked about from this capacity in a large way. So we as a department can really create and focus specific shadowing experiences within these flex weeks so that we can get early exposure to our students around pediatrics. So I would encourage each of our divisions to think about what are unique ways in which we could build a shadowing experience. We already know when the flex weeks are going to occur, so we can already plan ahead to develop that concept. A couple other really important ways is that all of our students, not going away, is the longitudinal research project. Students will do research on a specific project over their 4 years. The flex weeks give them the opportunity for some focused time to focus down on that research project while they're in the middle of their preclinical work. Traditionally, this has occurred during between the summer of their 1st and 2nd year, where they have some focused time, but we're offering opportunities for them to do this more regularly as well. And the final thing is, these will be able to be used for wellness. Not every single one. There's going to be a limit. And right now there's a debate, but at least one of them will be able to use for a wellness week, so that if a student needs that, that is an opportunity for them. And of course, the last one is remediation. The idea is that this is going to be a fast curriculum. We're going to be assessing students continuously. But if there's an area where there's a deficit, this is a week for a student to catch up without having to be already in the coursework. Traditionally, what happens now is if you fail an assessment, you have to kind of figure out, how am I going to remediate either during my summer or while I'm in the middle of coursework? This gives a dedicated time that students can remediate in the middle. So that is going to be our 10,000-foot view, understanding what's going on in the curriculum. Now, as we start narrowing down, we're going to just look at the first kind of basic science block, so that kind of first 9 weeks. And one thing that you're going to really quickly see, and is really important, is number one, there are no courses. So there is not a genetics course. There is not a microbiology course. There is not a biochemistry course. There is not specific courses. Instead, there are course leads who are working together to create integrated cases that students will work through on a weekly basis to get the content they need. Not only is there not going to be courses, there's also going to be no lectures. So instead of sitting in a classroom, our students are going to spend the heart of the curriculum is going to be sitting in case-based rooms with the same group of students, with the same educators, Tuesday, Wednesday, Thursday mornings, and working through the course and working together, bringing all their unique skills to develop this course. So I'm going to give you guys an example of how this actually works. If you look at one of those weeks is pneumonia. So the idea is they're going to pick specific disease processes that are key disease processes that integrate a lot of curriculum, but also are high repetitive things that we will see in the practice of medicine. You're going to go through a case of pneumonia. So you're going to hit on microbiology. You're going to hit on immunology. You're going to hit on pulmonology. You're going to hit on cardiovascular system, right? You're going to have all of these, and there's going to be key learning objectives that are going to be matched to those specific sessions. And we're going to have our content leads who will be supporting this development of this course. Now I'm going to move forward and look at what this looks like on a weekly basis in just a minute, but just to get that concept, as we're zoning in, there's going to be no courses, no lectures. Instead, we're going to be using cases to integrate the material in a structured fashion. So let's look at that week-long scaffolding. We're going to zoom way down in. So this is going to be like the 50-foot view. So an example of this on Monday and Friday, they're going to get some early exposure to the case for the next week. Maybe they'll get a case stem on Friday, so they have an opportunity to start thinking about that case, start doing some basic self-directed learning about that case. And then Monday morning, and we're going to actually in a few slides, look at a specific case and what that will round out to. But Monday morning, they may have some course content that they have to do in a non-synchronous fashion, watching some videos that set them up for the content for the week. Maybe there's some readings that are available. And then that morning, they're going to come together as a class, and in team-based learning environments, they're going to start hitting some of this major content in a workshop fashion that will set them up for when they move into the case scenario. So that by Tuesday morning, Wednesday morning, Thursday morning, they're going to be delving into a case. Tuesday morning, they may be focusing on differential diagnosis and critical reasoning. Wednesday morning, they may be focusing more on what is the treatment method and what are the different options. And Thursday may be a wrap-up session where they're going to be talking about, hey, what are the outcomes? What are possible complications? And what does this look like? And so we can see as they start working through this on a weekly basis, they're going to be in these small group rooms. Now, one thing I want to pop out, and this is an opportunity to talk about something that's unique in this curriculum, is this idea of dedicated educators. Now, before I jump in and talk a little bit about this, I want to just also highlight a big thank you to the work of Dr. Germany, Dr. Spears, Dr. Choi, who's in the audience, Dr. Szymusiak, who did amazing advocacy because these opportunities just came out of who was selected, and pediatrics represents 30% of all the dedicated educators in the curriculum. I think it's amazing. For a long time, geography has made it challenging for the Department of Pediatrics to be super integrated within the undergraduate education. But now we have put our stamp on it, and 30% of us, and I think there's many, many more opportunities for us to do this moving forward. So first, the longitudinal educators. We said that these case-based scenarios are the heart of the curriculum. Tuesday, Wednesday, Thursday morning, cohort of students, about 10 of them will be working on a weekly basis, the same group of students over time, but they will also be working with the same educator so that this group can develop mentorship, teamwork, and be able to develop a rhythm to how do we integrate together? How do we work together? How do we work through these cases? There will be some switching that occurs in the curriculum. So about every 4 to 5 months, so that there will be 2 switches so that there still is some cross-pollination, some diversity, but also by continuing some of that continuity as well. So then you've spent that week learning this core content. At the end of the week, there will be an assessment. There's going to be a formative assessment at the end of the week where there will be about 20 questions that will test on the content that was experienced. The opportunity for this is immediate feedback. So after you create a summative assessment, you will get feedback. So in the afternoon, there'll be an opportunity to remediate. This can look as an example of a content lead going through the questions and explaining the answers, making sure that our students have grasped what was supposed to be picked up during that week. A couple other really important highlights that I want to see within this curriculum. There's some additions besides that core curriculum. And one of those is what I call the patient panels. Because these are disease-based processes that we're going to be looking at as cases, we want our students not to only have a disease model, but a person-based model. So every week we want to have panels of patients. So for example, during the week thinking about lupus as our lens to think about medicine. We're going to have a panel of patients who have experienced lupus and what does that look like in their life based on different ages and different experiences so we can see the human side. There's also going to be panels that are going to be based on interprofessional experiences so that our students can not only think from the doctor perspective, but they can also think about what does our pharmacist think about this? What do our rehab specialists think about this? What do our nurses and our social workers think about this? What do our community partners think about this? So that we can kind of have a better view, right? Often in medicine, we think in our different boxes, but we want to break down silos, both thinking about educationally, knowledge, but also about how we care for patients as a team. So that's going to be a unique aspect of it. Another thing that's going to be a unique aspect is we're going to have the human visual atlas that's going to be integrated within the curriculum. So as you're doing a case, for instance, pneumonia, in the afternoon on Tuesday, you will go in and use Visual Human Atlas to be able to look at what does the pathology of pneumonia look like, both gross anatomy as well as histology, looking at microbiology, so that our students are not getting this siloed in those different courses, but integrated right within what they're doing. And the final thing I also want to highlight is this concept of this EBM, PPS, or population, patient population and society block. This is kind of a block that has traditionally been all these different ancillary courses, biostatistics, population health, ethics, equity, racism in medicine, health equity solutions, all these different courses that are key and foundational that we know as physicians, but not necessarily basic science of organ systems. This is what I call the hidden curriculum, right? These are the things that as we are physicians, as we walk through our day, every day, we are dealing and integrating with these aspects of care, but it's not necessarily anything anybody has directly taught us. And so the idea is, how do we make the hidden curriculum visible? And so the idea is this concept of threads. And the 4 threads that are really focused on in this curriculum is social medicine, interprofessional, critical reasoning, and leadership. And how this is going to happen is these threads have already been working with our content leads to look at these cases and add pieces within the cases. So as they're working through their cases on Tuesday, Wednesday, and Thursday morning, there will be pieces that the students will already be integrating with, thinking about these different threads, because we know how medicine is practiced is not in boxes, but all at one time. But also on Wednesday afternoons, there'll be opportunities for these core areas to have workshops that specifically focus on this content to set up the students also to have some very specific integration about it. The last thing I want to highlight in this week-long scaffolding is what happens in the afternoon. We know that the mornings are very heavy in-person interaction with the curriculum. In the afternoons, one of the things that's going to be really a great opportunity is a lot of independent learning. So only one day a week will there be specific mandatory in-person curriculum, and that's going to be our clinical skills course. Now, our clinical skills course is a really important part of the curriculum. It's where we teach our students how do we do medical interviewing, how do we do physical exam. And this is something that has worked very well, and it's going to be the same course content that we've been using throughout the curriculum. The biggest difference is now we're going to have dedicated educators. One of the biggest challenges about this curriculum is that you have been recruiting faculty throughout all of the university to fill in piecemeal different portions of the course. So you may have 150, 200 faculty members that are participating in all these courses over the first 2 years. Now we're going to have dedicated clinical skills preceptors. So we have 33 dedicated faculty to that. Their job is to partner with small groups of students continuously, 5 to 6 students, and walking with them through this curriculum so that it's not piecemeal anymore. Instead, we can do a better job of how do we build some of these skills? How do we build from medical interviewing to basic physical exam to advanced physical exam to advanced medical interviewing? How do we do that in a sustainable way? And once again, our faculty are representing about 30% of these individuals. So that'll be a great opportunity for pediatrics to be able to share our skills of how do we train physicians with those key skills of physical exam and interviewing. Now, I'm going to pause for a second of doing this deep dive on the curriculum and think about something that else is happening at the same time. We all have been through Oakland and seen tremendous construction going on. Good news, tomorrow is actually the opening of the new Scaffold renovation. In fact, if you are interested, between 2 and 4, there's going to be an open house and you're able to go to Scaffold and take a visual look at what this will be. This is not part of the new curriculum, but it is happening at the same time, and it was built with the new curriculum in mind. So I just wanted to share a quick picture of what new Scaffold will look like and how it integrates with this concept. So first of all, we want to think about space opportunities. There's going to be different space opportunities that are going to be learning environments. Now, one of those, right, is our traditional classroom. There is going to be there is one 160 team-based learning room. And this is your traditional classroom. You're like, why did they build a traditional classroom? There are no lectures. Because there's still going to be patient panels. There's still going to be interprofessional panels. There's even going to be sometimes master lectures where you may have somebody who's nationally coming in and teaching our students on something. So this space will be used in a limited but a very specific fashion. But there's also going to be these other team-based learning environments that are 80, 40, so larger rooms, but their design is based on team-based. So it's not a classroom in the sense of sitting in a chair and looking forward. It's sitting at tables with your team and integrating in a workshop fashion. And of course, the final one is the heart and the soul of this new curriculum, which is going to be our PBL rooms, or our small group learning rooms, where students will be able to kind of sit with their educator and work through the curriculum in a fashion. There's 18 of these new rooms. And of course, we still have our traditional wet labs and gross anatomy labs that will still be present within the curriculum. Okay, as I'm wrapping this up, I want to give us a more specific view of what it will feel like from the student to walk through a specific week in the curriculum. So what happens? So you're a first year medical student. It's about October-ish. And Friday afternoon, you're given this case stem that talks about weight loss and fatigue. So what happens Monday morning? Monday morning, you wake up. You know that you can go to the portal and you can say, what are the synchronous learning I need to do? So you review a couple of videos. There's some coursework that you can read through. There may be some questions that you can look at as a way to integrate with the knowledge to set you up for the week. You then get into Scaffold. It's about 10 a.m. and you're in your 80-person team-based learning room, and your content lead is there from microbiology, from endocrinology, and they're teaching you some very specific pathophysiology in a workshop fashion to set you up for the week. So then Tuesday morning, you go into your small group case room and you start doing a differential diagnosis, and you're working through weight loss and fatigue from a differential diagnosis. And you get to the diagnosis of autoimmune Graves' disease, and you start thinking a little bit about the pathophysiology of that. So that kind of wraps up, and it's 10 a.m. You go back to your team-based learning room with your other colleagues, and you're sitting around that big computer with 6 to 8 colleagues, and you're going through your visual human atlas, and you're understanding the pathophysiology of the thyroid gland and the parathyroid gland. You're understanding what goes wrong from a histopathology standpoint in Graves' disease. So the morning wraps up. In the afternoon, you have an opportunity to do some self-directed learning. And then Wednesday morning, you're going back to your PBL room and you get the opportunity to now think about treatments. What are the surgical and medical treatments? You're going to think about new symptoms that occurred in your patient as their disease stem progresses. Coming back Thursday, you talk about outcomes based on the treatment that you chose. And finally, based on that outcome, the patient now has hypothyroidism, and what does treatment of hypothyroidism looks like? At the end of the week, it's Friday. You get into summative assessment based on this stem, thinking about endocrinology, thinking about your hypopituitary thyroid axis, and you start saying, where are my gaps? Where are the areas I need to kind of fill in? And you can either go to the afternoon session with your content lead, fill in those gaps, or you can go back to some of your self-directed learning and find those gaps to be filled on your own. Either Monday, Tuesday, or Wednesday afternoon, you happen to be also in your physical exam course where they specifically focused on the head and neck exam, so that you're also, once again, integrating across the whole spectrum of the course. So that is what it will look like for our first year and second year medical students on a weekly basis. Now, real quick, I want to highlight 2 really special programs that are going to be sitting next to this new curriculum that I think are really vital to think about how do we actually make really well-rounded medical students. And the first one is the Community Alliance program. Now, why is there a Community Alliance program? What is the core part of this idea? So I want to take a little kind of statement from Liz Miller as she thinks about the Pittsburgh study. One of the things she really highlights in that study design is the idea that we don't do research on communities, we do research with communities, right? She built a research structure in which there's equal partnership between researchers and the community, and they think about ways in which the research actually comes from the pure community perspective to do work. So what does this have to do with medical education? Well, I would argue that currently how we teach our medical students to integrate with the community is very much a model in which our students find areas of need, they come in for brief periods of time and then step away. And it's not based on our students, it's kind of the structure that we've set up. And so the Community Alliance program is rather to teach our students how do they become part of communities, integrated communities, and then work together with the skills that the community has, as well as something uniquely they bring. This is going to specifically look like that we will have 16 community partner organizations that the university will help pay to support this work. And they will become community educators, where they will work with those small group of students in the PBL fashion. So those 10 students to think longitudinally what community engagement looks like. This will look like every other month, the students will go in their PBL room for 2 hours, and they'll have an opportunity to reflect on what that experience has been like, as well as some very specific workshops on what does community engagement look like. So we might do some asset-based assessments, thinking about what are the strengths the community has instead of looking at the needs of the community. The other thing that we will also do is that each of those cohorts of students will be expected to spend at least 8 hours a week in 8 hours a month in direct service within that community organization. So the idea is that with time and exposure, our students will get an opportunity to learn to break out of the silo of academic medicine and think more integrated in how healthcare is delivered within communities. The second program I'm going to highlight very briefly is the Longitudinal Alliance program. This is a program that's already been going on, and large cohorts of our students have participated in it. It's where our students are partnered with a specific patient and family over their 4 years, so they can see what it's like from the patient perspective as they experience healthcare. We've had many students who've partnered with some of our families in the Down Syndrome Center, and they come into the clinic visits, or they go with them to the hospitalization, or they go to their outpatient therapy appointments, so they can see what life is really like for our patients and families. This is going to, instead of being optional, every single one of our students will be participating in this starting the beginning of their school year. So this is a quick, brief overview of what it looks like for the preclinical years in the new curriculum. And I'm going to tag my partner back in, and John's going to talk to us a little bit about what happens during the clinical years.
All right. So thank you, Dr. McCormick. Hopefully that makes a little more sense to you all now. Some of those pretty large changes that are going to be occurring in the preclinical curriculum, what that's going to look like. So I'm going to give you a more big picture overview of the clinical curriculum because the changes are not as wholesale, but there are still some big changes and innovations that I wanted to make sure you were all aware of. So for the clinical year now, we're going to be thinking about a 12-month core clinical clerkship and then a 15-month bridges clerkship, kind of tying into our Three Rivers curriculum theme. The core clinical clerkships are going to run from February of the traditional MS2 year. So essentially students will finish their preclinical coursework in December. They'll have shelf study time in January, and then in February, they'll be starting their clerkships to February of the traditional MS3 year. So students will be finishing up 3 months earlier with their core clerkships than they traditionally would. And the way we kind of tried to approach deciding which of these clerkships should be considered core clinical clerkships is we wanted to identify the ones that A, provided students with those really important foundational skills they needed early on. That B, would help them aid them in their specialty selection. I suspect that probably among everyone here online, not every one of us started medical school on day one knowing we wanted to be a pediatrician. And then we did a pediatrics rotation and fell in love with it. So we want to give students early exposures to these kind of core clerkships so that they can get some practical experience and figure out what they like and what they don't like. And then finally, these are the core clerkships that are felt to be the highest yield in terms of step 2 CK material. And I'm sure, as many of you know, step 1 has now gone to pass-fail. The step 2 test is now taking on a lot more significance for students when it comes to residency applications and matching. So we want to make sure that every student early on gets these really foundational clerkships so that they can then be successful in having a study plan and doing really well in Step 2 CK. So the clerkships that are going to make up these core clerkships are peds, surgery, neuro, internal medicine, psych, family med, and OB-GYN. Surgery and OB-GYN will both be getting an extra 2 weeks to kind of bring them more in line with kind of what's being done at medical schools nationally. All the other clerkships are going to stay essentially the same. It is important to highlight that we did feel that we wanted to make sure students still had some built-in flexibility into this 12-month curriculum to pursue some outside kind of interest. So let's say a student's always had an inkling they're really interested in emergency medicine, they can do a 2 or 4 week elective in emergency medicine to get that practical experience. So all students will have 6 weeks of built-in elective time, and then students will have 2 weeks of flex time. That will be very similar to kind of what Dr. McCormick was describing, with the exception of probably not quite as much shadowing, since students are already kind of on the wards getting direct clinical experience. Well, certainly if there's like some specialists they worked with and they want to shadow, that would be an option. And I do just want to highlight there's going to be no major changes to the 8 weeks peds clerkship. It will still be 4 weeks of inpatient, 4 weeks of outpatient, with experiences in the pediatric emergency department, the newborn nursery, our outpatient gap practices, our PHM teams, and our inpatient subspecialty teams. So this is just a big picture snapshot of what the 12-month clerkship schedule will likely look like. Students will rotate through in 8-week blocks so that we can have a little better control over throughput and kind of make sure we have similar amounts of students going through each clerkship at each time. That also make sure that all the students are switching at the same time. And then they will have synchronous flex weeks. Right here, and this one we're blocked together in a 2-week block, but probably those will actually be split up into 2 1-week blocks. And you can see they have elective time that's tethered to some of the shorter clerkships to kind of make that 8-week block. Now let's talk about the bridges phase of the curriculum. So this will be 15 months, and really our goal here was to bring back a little bit of rigor to the 4th year. I think that both students and faculty agree that there were probably opportunities to increase the clinical rigor of the 4th year for our students. But we also wanted to do so in a meaningful way, right? It's not just making them do hard rotations and spend 40 hours in the hospital. It's making them do so in a way that's going to be beneficial to their learning and set them up to be rock stars as interns in whatever program they match into. So our goal was to still give flexibility, but also make sure that we're maintaining a rigorous learning environment. So during these 15 months, all students will complete an AI. Some may do several AIs. We're expanding the number of specialties that AIs are available in, and certainly pediatrics will remain one of the core AIs that many students do. Students will complete an acute care month, where they'll be spending time either in ICU or in the emergency department. And this is meant to be an opportunity for senior students to apply those skills to the more medically complex and sick patients, or kind of the fast-paced, undifferentiated patients in the emergency department. ILS is being reimagined a little bit. They're still kind of working on exactly what that will look like. The goal very much is going to be, now that these students have this strong clinical basis, re-exposing them to some of this basic science content through this new lens that they have after these clinical experiences. It's probably going to be more synchronous, offered over 1 or 2 months to the majority of the students. We'll be a little more standardized in the ILS now, but that's still kind of being worked out. Students will still do 2 weeks of anesthesia and 4 weeks of ambulatory medicine, internal medicine, but those will be able to be done at kind of their discretion. So either during the elective time during the clerkships or during this bridges phase of the curriculum. Students will do an advanced longitudinal clinical experience, which is a new addition that I'm really excited about, and we'll go in a little more depth. And then we mentioned pretty much all students will take a month of Step 2 CK study time, and obviously have some interview time too. Let's talk a little bit about changes to the electives. So I know there are a lot of really incredible pediatric electives that are offered. Electives are going to be being restructured a little bit in this new curriculum. And the way we're envisioning it is that there's going to be 2-week appetizer-sized electives and 4-week entree-sized electives, which I guess they mix with the AI, like the tasting menu option. But the 2-week appetizer size electives are going to be for students who either want an exploratory exposure. So like, I haven't done much ortho, but it's always sounded cool to me. I want to just kind of do a exposure for 2 weeks to figure out that I want a deeper dive. Well, this could be something where students like, this isn't going to be something that's directly relevant to my future practice, but I'm never going to have an opportunity to go work in this environment again. So I want to just get a 2-week exposure to kind of see what I can learn. Then we have this 4-week option for students who really have a really vested existing interest. So like they've rotated and shadowed orthopedists throughout the undergrad. And they're pretty sure that's what they want to do, and they want to dive right into a more kind of meaty experience. Or for students who are like, all right, I really want to do that Peds ID elective because I've heard it's such incredible education and it really prepares me for residency. So we have both of these options, and a given elective can also have a 2-week and a 4-week option. This is just a little warning shot to our elective directors to start thinking about, is there one or the other option that makes the most sense for your elective? Do you have the opportunity to do both? But this would be a little bit of a change to the current structure where everything is 4 weeks. And finally, one of the new innovations that I'm really excited about and wanted to highlight is the advanced longitudinal clinical experience. So this is going to occur longitudinally over the 15 months of the Bridges portion of the curriculum. And students are going to have an opportunity to spend anywhere from 2 to 4 half days per month working in the same clinic with the same provider or co providers, really kind of very similar to the existing residency continuity clinic model before the shift to XYZ scheduling. And we're really excited for this opportunity for students. We think it's a great chance for them to get really in-depth mentorship with a provider, which can be really crucial to professional identity formation. And also can be a great opportunity to get a really meaningful letter of recommendation from someone who worked with over a period of months. We also think this is a great way for interdisciplinary education, right? Because not only are we going to be working with the same physicians in that office, but they're going to be working with the same APPs, the same MAs, the same interdisciplinary, or the same members of the multidisciplinary team. So I think that's really the best way to get that kind of in-depth understanding of how the multidisciplinary team works together to care for our patients. And we're going to try to offer this in most of the core specialties. The assumption is that most students will probably choose to do this in their specialty they're intending to go into for residency, but certainly it wouldn't be a requirement. And these would be great pass-fail. And we'd really like to actually be able to map some of the entrustable professional activities that are the most relevant to kind of starting residency to this as well. So while the grade will only be pass-fail, the students will also be getting formative feedback on what they're doing in these really key milestones that will set them up for success in residency. And there will certainly be an ALCE that's going to be offered in pediatrics. There's been several members of our GAP faculty who were members of this working group in the last phase of curriculum reform and are already thinking about how to make this work in pediatrics. And finally, I want to briefly highlight something that's coming down the pipe, which is the primary care accelerated track. So students are going to have the opportunity to apply and be accepted into a 6-year combined medical school and residency track. And all of these residencies will be in the UPMC residency programs. And really the goal of this is to be training primary care physicians. Currently, this current cohort had the opportunity to enroll in this program in family med and internal medicine. And our hope is that Peds will be able to start offering 2 positions for this starting in academic year 24-25. All right, so that was a whirlwind tour through the curriculum. I want to highlight some concrete next steps that I would like to encourage all of our faculty to be starting to think about, and we'll have a time for a few questions. So firstly, we want everyone to be thinking about ways to get engaged in the new curriculum. So in the preclinical setting, as Andy highlighted, this would probably be shadowing, formalized shadowing opportunities for students, doing these PECs or mini courses during flex weeks. And also, I know it's hard to believe as we just finished enrolling the current cohort of longitudinal educators, but there's going to need to be an entirely new cohort to work with the incoming virtual class, right? Because the current cohort will follow the classes starting this coming August throughout their 15 months. So we're going to need an entire new cohort. So if it was something that you were thinking about, but maybe you weren't quite ready to take the plunge, there will be a new call for applications, hopefully much earlier in the academic year. And you will also have the opportunity to pick the brain of many of our faculty who have already been serving in these roles. we already talked about thinking about creative and electives and experiences for our students. And then finally, globally, I just want everyone to kind of be, as they're interacting with students who have come through this curriculum, cognizant that like their educational experience before they came onto the wards is different than every other medical student you've interacted with here in Pitt the last however many years you've been here. And there's probably going to be things these students have more strength in because of the new curriculum, and there may be areas that are more areas for improvement as well. So I want everyone to kind of, as we begin to transition to this group and you start working with them in a few years, just be kind of thoughtful that their educational experience has been different and they're bringing different things to the table. So thank you everyone for your attention and attendance, and we have time for a few questions, I think.